If you enjoy listening to clinical conversations, why not become a member of the Royal College of Physicians of Edinburgh? Our membership provides you with access to the RCPE educational portal, the live evening medical updates, and you have options to view the symposia both in person or online. If you would like to learn more about this, please go to the Royal College of Physicians of Edinburgh website.
Hello and welcome to the Royal College of Physicians of Edinburgh Clinical Conversations podcast. My name is Ben Warner and I'm a respiratory medicine specialty registrar, currently at a programme while I complete a PhD in multimorbidity. I am delighted to be joined today by Professor Frances Mair, who is the Norie Miller Professor of General Practice and Head of General Practice and Primary Care at the University of Glasgow, as well as the Director of the Wellcome funded Multimorbidity PhD programme for health professionals, of which I'm a fellow. She undertakes mixed methods research focusing on optimizing the care of people with chronic illness and multiple long-term health conditions, or multimorbidity, and she leads an extensive program of chronic illness, multimorbidity, and digital health research to the extent that she is among the top 1% of researchers with most cited papers. Frances, thank you so much for joining us. Welcome.
Thank you. Thank you for having me.
Frances, you've kindly agreed to come to talk to us about multimorbidity, which is a term that has been used in the research literature for a bit over 10 years now, although obviously as a phenomenon, it's been around for much longer. I think before I even started considering it as its own distinct entity, I was aware of it, as I found that whenever I would review patients in the acute medical unit, I'd always start by making a headline list of their current conditions and found that I would be surprised and often even end up looking harder if a patient appeared to only have one or no conditions. So evidently multimorbidity has been the norm, at least in acute inpatient medicine, for some time. So I wondered if I could start by asking you perhaps to introduce yourself, giving a bit of background about your clinical and research interests and how you developed an interest in multiple long-term conditions or multimorbidity, and perhaps even by beginning by explaining what we mean by the term multimorbidity.
Thank you very much. So multimorbidity refers to people having two or more long-term health conditions. And in work that we've done with our patient and public partners, we know that people don't like the term very much. And so we generally talk about people having multiple chronic conditions or multiple long-term conditions rather than multimorbidity. Certainly when we're doing our public events, then that's the term. We stay away from multimorbidity as a term. So I'm a general practitioner and I've actually always been interested in chronic illness. And I started off being particularly interested in patients with heart failure. And then a bit like you were describing, it became very clear to me that 98% of people with heart failure have other health conditions. And increasingly what I see in my practice, in my clinical practice, is people who have multiple health conditions and complexity, really. And it became very clear to me that we had a problem with people with having multiple health conditions. And in fact, before multiple long-term conditions became popularized, or multimorbidity as a term, in 2009, I wrote a piece in the BMJ with Victor Montori and Carl May, where we were calling for minimally disruptive medicine. And we said that we needed healthcare that was much more focused on people's individual health needs, and that our poor patients were being overwhelmed because of all the tests, investigations and appointments and medications that they were having to take, and that there was a great risk that people were not benefiting from the evidence-based medicine, from all the clinical trials we have, because they couldn't adhere to treatments. And then we talked about this being structurally induced non-compliance or non-adherence, because actually the way we configure healthcare systems is very much focusing on people having a single disease and don't really take account in the way we plan or develop services about how you deal with people who've got multiple diseases. And our care that we provide is often very fragmented and very siloed, and poor communication and poor coordination. And this actually gives a lot of work to people who have multiple long-term conditions, and a lot of work to their families and wider support networks who have to help them. And then it kind of followed on from there that multiple long-term condition research became popularized. My work just gradually moved into looking at the problems people experience and also about the epidemiology of people with multiple chronic conditions.
That's brilliant. Thank you. That gives a wonderful insight into where patients are situated within the health system and their interactions with it. And I think we'll come back to the idea of the burden of treatment in a minute. Perhaps while we're talking about multimorbidity and what it is, I wonder if it would be helpful to clarify what it's not, because another term that many physicians are very familiar with, particularly geriatricians, is frailty. But I think there is a clear distinction between frailty and multimorbidity or multiple long-term conditions. And I wondered if you'd be able to describe how you would differentiate the two ideas.
They are overlapping in many ways. Frailty is a key concept for healthcare, particularly as people age. But multimorbidity or multiple long-term conditions refers to people having two or more long-term conditions. That's the definition, whereas frailty is defined as being a kind of dynamic state of increased vulnerability to adverse health outcomes. And it results from loss of physiological reserve. So the two often coincide so that you can have multimorbidity and frailty pre-existing, but you could also have them quite separately. So you can have a frail person who has not got multiple long-term conditions, and you can have people with multiple long-term conditions who are not frail. And we've done work in UK Biobank. UK Biobank is a large research cohort of more than 500,000 people in the UK, and it has lots of variables measured. And one of those things that was measured was frailty, and it also has a list of multiple long-term conditions. And so we were looking at prevalence of frailty in people with multiple long-term conditions and frailty of the people in the UK Biobank. Now, interestingly enough, UK Biobank is a cohort of people from age 37, so it's not an older population, it's not over 65. And we found that 3% of the UK Biobank population from age 37 were frail and 38% were pre-frail. And the prevalence of frailty in people who had 4 or more health conditions, who had multiple long-term conditions, was 18%. So basically, as you increase the number of long-term conditions you had, your multimorbidity count or your multiple long-term condition count, then your likelihood of being frail increased. But while they're overlapping concepts, they are distinct and can be measured. And we do research looking at people with frailty, and we often control for the number of long-term conditions to actually adjust for that as a confounder. So we can look at us as distinct. So they are complementary and they often coexist, but they are distinct concepts.
Brilliant. Thank you. Okay. So with a clear idea of what multiple long-term conditions or multimorbidity is as a concept, I wonder if we could explore a bit what that might actually mean in terms of, for the experience for patients, how it affects quality of life, perhaps from your research and your clinical experience, and perhaps you could tell us a bit more about the burden of treatment theory that we briefly touched on earlier. What is it about multimorbidity that's greater than the sum of its parts?
So it's probably worth me stepping back and also defining something else that's often used as a term, which is comorbidity. People often think of comorbidities. So the respiratory physician like yourself will think of the person with COPD and they've got these other conditions. And when we're thinking of people with multiple long-term conditions, conceptually, it's quite different. So when you talk about comorbidity, the idea is somebody's got this problem, diabetes or asthma or COPD or heart failure, and they have these other conditions. So my focus is on their diabetes or their index conditions. And I'm kind of taking account that they have these other things. So I maybe think about my prescribing about drug interactions or risks. But my focus is on the single disease. Whereas when we're thinking about multiple long-term condition care, it doesn't really put a focus on any specific disease. It's looking at the person having this whole set of problems and how would you best deal with them. And it would take account drug interactions and drug disease interactions and also their wider care. So they're kind of distinct concepts. And there was a guideline brought out by NICE in 2016 looking at multimorbidity or people with multiple long-term conditions. And one of the things it showed is they have a nice figure in that guideline which it says you accumulate long-term conditions, the complexity of your care and the number of doctors you see increases greatly. And as a result, you get more and more fragmented and poorly coordinated care. So actually, as your health condition becomes more complex, you have a whole lot of different people inputting to your care, but there's actually no coordination of that really, other than what the coordination you might have from your general practitioner as your coordinator, but you're still going off to see lots of different people. And this is a real challenge. And we've referred to this challenge as being the burden of treatment or the self-care demands that we put onto people and the impact that that has on well-being. So burden of treatment is quite subjective. So two people could have a similar healthcare workload. Two people might both have 20 medications and 5 health conditions, and one might be doing very well, and one might be struggling and feel very burdened and feel quite differently. And that could also change over time. So it might be For instance, I'm doing well with my 5 conditions and 20 medications because I've got a supportive partner who helps me get to appointments. And if I've got a bit of memory problems from my heart failure or some of my other conditions, can help remind me to take my tablets. But for instance, it might be that I have that helper this year, but next year they die or they become unwell or they leave the scene for some reason. And suddenly I'm not coping anymore, or I can't manage that given level of workload of self-management, of burden of treatment. So it can vary between people depending how many people who are isolated, who might live alone and don't have supporters, might struggle more than somebody who's got a wide support network that can help you. So burden of treatment is quite subjective, we think, but there are various elements to it. So we talk about the work that people have to do. We talk about the sense-making work that people have to do, the work that you have to do to gain an understanding of not just one condition, but multiple conditions, and also of the medications that you have to take and learning about their interactions. But increasingly, as medicine advances and things become more complex, it's not just medicines, it's often devices. You might be somebody who gets an implantable defibrillator, which is great, but then you have to learn about the implications of that for your well-being, and also over time, what happens when you become even more unwell or maybe reach a palliative medicine stage. You have to make decisions about what does that mean, deactivating a defibrillator. Does that mean I'm going to drop dead, or what are the implications for me? So there's a lot of work patients have to do to gain an understanding of their conditions and its implications. And sometimes that's not straightforward because they have lots of different people giving them information. And also sometimes people just don't actually have that information or haven't taken it in or haven't understood it. Have poor health literacy. So that is a struggle, and they look on the internet and they get misinformation, which makes it difficult. And all of this is work. They also have to do work engaging with others about their self-management. They might have to engage with the GP and the pharmacist to get their repeat medications. And people are on 20 different medications. I'm often told, every time I put for my repeat prescriptions, I get almost all my medications, but there's always one that's not there. And then they have to chase with the pharmacy. So I haven't got it from the GP. And then there's a whole lot of back and forth. But you can imagine doing that every month. But it's not just that, it's maybe engaging with family members to help you get to appointments or helping you to remember to do things. So there's all of that work, engaging with your general practitioner to try and get referrals if you think you need specialist input or you need aids or adaptation. So that work of engaging with social work or others about your care. And then there's the work of operationalizing self-care, actually taking those medications, enduring the side effects of those medications, dealing with fragmented care, having to tell different doctors and nurses the same story over and over again, having to go for different appointments. I once had a trial for patients with heart failure, actually. It was providing heart failure nurse support in the primary care practices a long time ago. And I remember there was somebody, we were asking people why they didn't participate in the trial. And one gentleman said to me he didn't participate in the trial, not because he thought it was a bad idea, but he said, I've been to 51 appointments this last year.
It's incredible.
So sometimes I think we underestimate how many different places people have to go for appointments. And then there's the work people do of monitoring, increasing, if you've got your diabetes, self-monitoring your blood sugars, or we ask people to monitor their blood pressures at home, and the work you do to kind of judge, well, am I going to carry on taking these treatments or am I not? Are the side effects, I think, more than I'm willing to endure? So all of that is a lot of work that people have to take, and people will vary in their capacity. If you've got lots of illnesses, that may affect your physical capacity in itself. Just if you've got multiple long-term conditions and you're frail, going to a hospital appointment that requires 2 buses might be quite a daunting task for you. So your physical abilities will affect you, your mental abilities, if you've got some cognitive impairments or memory problems as a result of some of your conditions or of the medications that we give you that sometimes can give you a bit of a brain fog, then that can make it more difficult for you to take medications. It can also be affected by your financial status. If I can get a taxi to the door of the hospital, maybe I'm more likely to go than I have to get 2 buses when I'm not feeling well. It could have to do with the other life workload that you have. We all think of people with multiple chronic conditions just thinking about their chronic conditions, but they might be working as well. They might also be caring for somebody else. I often have a slide up which shows somebody pushing a wheelchair, and I say the person with the multiple long-term conditions isn't the person in the wheelchair, it's the person pushing them. So, these people have lots of competing demands on their time. And also you think about individual factors, there's personal factors and thinking about health literacy and things like that and how that can affect your ability to engage and also your environment. We ask people, for instance, to adopt lifestyle changes and to be more physically active and to lose weight. Much easier to do that if you're in an affluent area and you're a member of a local gym and all of that than if you live in an area where actually you feel at risk when you're going outside. You don't feel safe. It's not very appealing, the outside. So these environmental factors will affect you as well and can affect your capacity to manage. And we've looked at this not just in the UK, but also globally. We've done some work in low and middle income countries where we've looked at the idea of burden of treatment to see if some of these concepts that we have in developed and high income countries apply in these settings. And actually we have found that some of the ideas or concepts are quite generic, but there's also additional issues. For instance, in low and middle income countries, what we've done with people with multiple long-term conditions in Malawi, where we felt that lack of treatment was a burden of treatment for people knowing, actually, I need care for my diabetes, I need medicines, but I can't afford them, or they're not available, or there aren't any doctors with expertise in this area, or I can't get these tests done, then that's a problem and affects people's capacity to self-care too. But also that there can be other types of things that can affect your capacity. Work we've done in South Africa has shown that precarity and cyclical precarity can affect people's capacity, and that can be precarity at various levels. So socioeconomic deprivation can be something that affects people, especially if you're living in a country where healthcare is not free at the point of access can be an issue. It can also be risk of violence. So women in rural South Africa living with multiple conditions told us that actually to get to the clinic, they had to cross a forest, and women were often sexually assaulted in that forest. So they then had to time when they went to the clinic so they were with other people, and the same for coming back. So there are all of these things. Part of his burden of treatment for them getting there, part of the issue is about the risks and difficulties that people have. And I think one of the things I think is important for clinicians and for healthcare systems is to be aware of this, because to a large extent, we just tell people what we want them to do without thinking very much about, one, whether they think it's the right thing for them to do. We might think it's the right thing for them to do as professionals, but do they think it's the right things to do in their circumstance that they're living with? Does it fit with their goals and priorities? But also, even if it does fit with their goals and priorities, even if they do think it's the right thing to do, can they do what you're asking them to do? Or are they going to need some kind of assistance to do so? Because if we don't think about these things, then we're going to send people off out the door, and that's fine. We might feel we've done our job, we told them what they need to know, but if they can't enact those treatments or those changes to their life that we know the evidence says will be beneficial to them, then we've achieved nothing. So that's why we're very interested in trying to raise these issues, to try and see, for instance, about how you can measure burden of treatment. And there are now 3 measures of burden of treatment. And we're thinking also about how you can assess people's capacity and these kinds of issues to think about interventions that can make a difference. But I think one of the most important things I would say is that I think healthcare systems and practitioners need to think about making things simpler. And sometimes we do it. I mean, I remember there used to be a time when I was trying to get somebody diagnosed with heart failure where I would have to send them to an ECG one place, and I'd send them someplace else to get their bloods taken, then get their echo, and then you see them to heart failure. And yet other places, we have nice one-stop shops. So you get a blood test. If it's raised, they can get their echo done on the spot, or they can get the ECG and echo and see a cardiologist on the spot. The breast clinics have this very well for ladies who have breast lumps, that you come and you see, and you can get your mammogram and you can get your needle biopsy and these things all done, and you get told your result on one go. And I just think we need to think more about how we could make services smarter for people with multiple long-term conditions. And I give an example from general practice. We often have patients come to us with breathlessness. Are they breathless because they've got heart failure, or are they breathless because they've got chronic obstructive pulmonary disease? Are they breathless because they're morbidly obese and they're unfit? There are lots of reasons. But, we send people up, they might have a raised BNP, and we send them up to get their echocardiogram, and then it comes back normal. They come back to us, they're still breathless. So then we send them to spirometry, or we give them chest x-rays or CT scans, and they might have to go to many people to try and get diagnosed. Same with chest pain. Go to the cardiologist who'll say, well, it's non-cardiac chest pain. The person still has chest pain. Then we have to think, is it dyspeptic chest pain? Is it musculoskeletal? Is it mental health issues? And look at that. And actually, maybe we need to think more about having symptom-based clinics, or I just think we need to think about working a bit differently from where we are. And I guess another issue in relation to that is the way we have siloed cares and we think about efficiency. So everything is about trying to get more and more people through the system as quickly as possible. And that's probably not the priority for people with multiple long-term conditions. So continuity of care and relational care is really very important and highly valued by these people who have complex care needs. And yet, increasingly, we try and put district nurses, which used to be attached to general practices, are now in hubs so they can see people. And that's more efficient because obviously a district nurse is off sick, the other one from another area can cover them. But is it helpful to have somebody seen by a different district nurse every day for a certain type of care when they're being followed for their wound healing, from their ulcer, which they've got with peripheral vascular disease and their diabetes and their COPD and they're immobile? Is it helpful to have a different person every day seeing them? And we do need to think about whether by being inefficient in this way, by not having relational care and continuity and fragmented care, whether we actually have people having more exacerbations and turning up to A&E more in crisis states because we're not intervening in timely fashions and picking up when there are problems. So I think there are lots of challenges that are posed to us by people with multiple long-term conditions.
There's so much there to think about and to get stuck into, but that was a really comprehensive overview and a very salient reminder. I'm really glad you touched on the fact that multiple long-term conditions is clearly a problem that is facing the global population and not just in high-income countries, but as low-income countries like Malawi transition epidemiologically, they're facing many of the same challenges and more. I think what you touched on about the ideas of capabilities of dealing with the burden of treatment really gets to the heart of how multimorbidity really seems to exacerbate health inequalities, and particularly people who have the capability to attend multiple appointments, or even, as you mentioned, the health literacy to navigate those really complex systems, will find perhaps less of a burden of treatment than someone who doesn't have the support systems in place. I wondered if you might be able to touch a bit more on how health inequalities play into multimorbidity. I appreciate in more socially deprived populations, we know that it often occurs at a younger age.
So I think that's a really important point. So we know that socioeconomic status is really important with multiple long-term conditions. And there was a kind of iconic paper that was in The Lancet over a decade ago by Barnett et al. And that paper showed very clearly that people from the most socioeconomically deprived backgrounds developed their multiple long-term conditions a full decade earlier than their more affluent counterparts. So people who live in areas of socioeconomic deprivation are much more likely to experience multiple long-term conditions and are more likely to experience it at a much younger age. And I think clinicians will see that in their everyday practice, and it's very visible to them. We've done work in socioeconomic deprived communities in Glasgow, where I work in Drumchapel, and worked with people with multiple long-term conditions too, and spoken to them about their experiences. And something that came through very loud and clear was the fact that people in these more deprived communities often feel quite stigmatized and feel that none of the systems work for them. And that's very true even of healthcare systems. And as a result, they often say they don't bother engaging because what's the point, really? Because these systems are just impenetrable to them and clearly are difficult to navigate. And this is where the idea of relationships and continuity really comes in, and person-centered care is a very key theme from that work. Has been that people sometimes felt if they had a GP who they had a relationship with, who they felt could be their advocate, then actually that could make quite a big difference. And we know that in other contexts, for instance, in specialist heart failure nurses, if they're known to somebody that they can call on and rely on to turn to, then that can make a difference. So that's why I think, particularly in these more socioeconomically disadvantaged communities, this relationships and the importance of continuity is really important. And the idea of having advocates and people who are on your side within the healthcare system really matters.
I wonder if I could pick up on that point about the idea of continuity of care, because again, thinking of multimorbidity as opposed to comorbidity, many of our listeners are based in secondary care and many are trainees in medical specialties. And as you said, we'll often see patients with, from our perspective, an index condition and multiple comorbidities. And we often think of GP and primary care as being it probably is the ideal place to oversee or coordinate the care of patients with multiple long-term conditions. What do you see could be the role of the general physician, or how can we in secondary care approach patients with multiple long-term conditions to do justice to that concept of the burden of treatment, to acknowledge that we are only one part of a bigger system. And how would you advise a secondary care physician to approach multimorbidity?
So I do think that a bit like the general practice situation, continuity would be helpful. And it actually, over my many decades, I have to say, in clinical practice, there's been a big change in that. Now we have very anonymous secondary care systems, often where people get referred. We refer into a specialty, and there's nameless doctors in hospitals who look after patients, whereas previously you referred to a named consultant, and people were very clear about who their consultant was and who they would go to if they had a problem. And I do think we need to at least move to a system when patients are being by specialists in secondary care, is, they go away with a very clear card. Dr. So-and-so is responsible for your care. And if you're having problems, this is who you could call. But we actually try to make systems very opaque, I think, for patients, and very hard for them to know to call. And the same goes for primary care. I think that often we don't know who to call in secondary care if there's a problem with that patient. And I think trying to increase and improve the communication across the primary and secondary care interface would be really important. And I think the other thing to do as a clinician in secondary care is it is possible for you in your care to still ask those questions of people when you're telling them this is what you have to do, to kind of acknowledge that, you're here today to see me about your diabetes or about your chronic lung disease and things like that. But, we know you've got lots of other problems here. I'm suggesting this would be the best treatment for you at this point. Does that seem okay to you? So checking with them and then saying, do you think you're going to be able to take that treatment or do those things? Because that's something very simple that anybody can do. You don't need to just be in general practice to do that. You can do that in the hospital setting, and to be clear about that, and they may say, yes, they can. But if they say, well, actually, there's no way I'm going to be able to get to here, or I'm going to be able to go to that clinic. Often people maybe get advised to go and see the physio or to go and do this, but actually they don't engage because they know they can't get there or something. Better to know that and think, well, what can we do that would be within the realms of possibility and feasible for you than doing that. And I think also, again, this communication between primary and secondary care, and it's a two-way street. It's just not always getting a specialist. Primary care clinicians need to write letters that provide a bit of insight to people's difficulties and challenges. And then equally, it's useful to get that feedback and very clear instructions back, because often there's quite mixed messages. I think there's also the issue about having a long lag time between somebody being seen at a clinic and actually coming away and us getting the letters. So I do think there's a system issue about that. For instance, in Scotland, we have a system for general practitioners. When we do a referral, it goes through Sky Gateway system, and that's an online portal, and it's immediate and it's there. And I know this isn't within the control of any specialists, but actually the healthcare system needs to think, well, why don't we have a system on the way back that's identical? I see somebody and something goes back very quickly. And especially as we enter into a time when we have AI and other technologies that, maybe you could dictate something into an artificial intelligence kind of large language model app, and it could just kind of say, these are the key messages or the key actions, so it doesn't even need to be a long letter. What people want to know is what are the key actions that need done for this person, and what are the key monitoring steps, and what's the key follow-up. So I think there's something about thinking in the longer term about how we improve communication between the sectors. And even if that's having everybody who leaves the clinic having something that they take away that has the key messages, or something very brief. These are the 3 key things you need to do, or these are the 3 key medicine changes you're going to need to make. Because I think there's a real problem for patients and practitioners of being unaware of what's going on, and that's a problem for them as well. But I think we also have to think about how we configure services in the secondary care setting and what we can do to try and help get things done when people come to a clinic. How can they get everything done? And how do we make sure about investigations that you order don't get lost in the system, people get back? And I think that's a real challenge for colleagues in secondary care's follow-up of appointments. And literally we have it on the BBC News, I think, just in the last day or two, talking about the problem about people being lost in the hospital care system and follow-up appointments being lost to follow-up. And that's a system problem. But I think our systems, we need to revisit them and say to managers, actually, it's not just getting people through the front door quickly that matters. It's how you manage these people over a long time. Providing good longitudinal care decrease the pressure on secondary care in the long term. So I guess one of the problems we have is very short-term views about healthcare policy. And I think we need a much longer term strategic view about investing in preventive activities now that will decrease the pressure in the longer term. And I do think better care coordination and thinking about how do you provide more holistic, joined up care actually be helpful to people with multiple long-term conditions and will be helpful to the healthcare system in the longer term.
Absolutely. I mean, I think that is very much a lesson that certainly medicine for the elderly seems to be embracing, and many other medical specialties perhaps could learn from. And perhaps some of that longer-term strategic thinking, I can imagine, suffers from being within a healthcare system that often feels perpetually in crisis. I really like that very easy thing to incorporate into clinic that you mentioned of asking a patient how they feel about doing what you've asked them to do. I think it's not uncommon in clinic for us to feel we're duty-bound to rattle off all these recommendations almost to cover our backs. But the reality is that which of those things can the patient really do? How do we prioritize that? How does the patient prioritize that? And I think that speaks to the nice guidance that you mentioned, which I believe was one of the first of its kind in the world on the management of multimorbidity, which, having gone through it, is a really nice summary to me of how to practice good medicine. I'm not sure that it needs to be exclusively to multimorbidity. Are there any other highlights from that guidance that you would recommend as take-home messages? I think you'd mentioned about identifying patients with multimorbidity or at risk of struggling with multimorbidity.
It's about focusing on providing person-centered care. And I think we need to do more work to understand that, because it's interesting when you look at the literature on person-centered care, people with chronic illness and multiple long-term conditions haven't actually contributed to that much. It's very much medical people have decided this is what person-centered care should look. So I do think we probably have to revisit what is person-centered care and what are the priorities. But I think thinking about what people's goals and priorities are and the context in which they're living is really important for them, because what my goal might be for somebody might be quite different from what their own personal goals, and same for the priorities. And I think this idea of a bit more emphasis on shared decision making and talking about what's important to them and why you're giving the advice you are, because I think it's also important to be sharing with people, like, why am I trying to control your blood pressure more, or why am I trying to get you to lose weight, or why am I trying to get you to stop smoking, having those discussions. But sometimes I've been told by people, I know smoking's bad for me, so there's no way I'm going to stop smoking because I'm too stressed, but I'm not going to do this or that. In that context, it's worth thinking about, well, what are there other risk factors that are there that perhaps they could address? And we have some research looking at wider risk factors that could be addressed. And can you get somebody that can achieve something that's positive in their life, even if they can't achieve? And you might think it's the most important thing. It probably is. Smoking's a terrible risk factor for chronic disease, but just thinking about what can they achieve for them, because you're better to get some small achievement that they can do than just fail to do anything and give it up. So I think some focus on that is really important. But I think there's a lot that we still have to learn about people with multiple long-term conditions. I think we don't know sufficient about how different combinations of conditions affect people. We know that type as well as long-term condition count matters. So we know, for instance, that people have chronic kidney disease as part of their pattern of multiple long-term conditions, for instance, do worse in hospitalizations and mortality and health outcomes. So that's important. And you mentioned quality of life, and I haven't spoken too much about it, but there's a very clear literature that shows as you increase long-term condition count, then quality of life in general decreases. We've got some work that hopefully will be out soon, which is looking very much at different patterns and clusters of conditions. And it certainly seems that if you've gotten certain clusters, like clusters of painful conditions or substance abuse or mental health, so there may be particular clusters of conditions that are particularly poor for quality of life and have a particularly adverse effect on quality of life. So I think there's a lot of work still to be done to think about what are the risks of different patterns of multiple long-term conditions that matter. And also, it's not just type and number. Of course, it's the severity of these conditions. You might have very well controlled and mild kidney failure and mild heart failure and diabetes. It's well controlled. So although you've got three conditions, you're clearly not going to be on a par with somebody who's got CKD5 and who's got diabetic retinopathy and who's got NYH4 heart failure. So severity matters as well. And a lot of the literature doesn't really address that. And that's because it's difficult to measure. Like if you're doing epidemiological work, often you can look at codes to see what conditions have, but often severity is difficult to measure. So I think there's still a lot of work and research that we need to do, but I just think there needs to be a need to think about how can we work smarter in the way that we configure services and to adapt to the need of a population where 1 in 3 people have multiple long-term conditions, and that's just going to increase. And to think about how, for instance, new technologies and digital innovations could help us in an equitable way without widening health inequalities to work smarter. We provide healthcare the way we do just now because it's how it's always been done. And that's not actually a very evidence-based or good way to deliver healthcare. So I do think we need to think about that. And I think we talk about having geriatricians for people age over 65. And I do think we need to stop being so age focused and think about what people's needs are. Why can't we be providing that more general medical care to people who are younger, especially in socioeconomically deprived areas when we know they're going to get those multiple long-term conditions at a younger age? We put arbitrary age ranges, and I know part of that is because of resources, but it's probably unhelpful. I had a gentleman who had multiple long-term conditions recently. He has a lot of problems with postural hypertension, falling a lot. I've referred him to the fall service. Fall service only takes people over age 65. He was 64, got told no. And in that interim, from me doing the referral to that, he had a fall. He had a subdural hematoma. He got admitted to hospital, then is in hospital for several weeks. And I felt quite frustrated because that's really avoidable, if he'd had that type of input. And yet we have rules like, well, you can't see when he's over 65. But actually, if it was more centered on the person's needs and more tailored care, actually more of a precision medicine approach that takes account of people's contexts and their clinical situation rather than just an arbitrary system where they have to be this age or they have to have these criteria, then actually I think we would do much better. A one-size-fits-all approach to clinical care I think is actually not very helpful, and actually I think in the long run is not economical and cost-effective for our healthcare system.
Absolutely. I suppose related to that, I'm talking about the sort of evidence base underlying much of what we do. A huge amount of that evidence base is looking at individual conditions in isolation, excluding those with multiple long-term conditions. And you mentioned about, as we learn more about multiple long-term conditions, how we'll perhaps draw out different clusters of conditions and different patterns. What do you think is the role of guidelines in multimorbidity? Do you think there will be a role for guidelines for each of these clusters, or does it require a sort of higher order approach rather than simply treating it as another novel condition? Is this precision medicine going to be more guided by clinical acumen and holistic approach involving the patient than just having a guideline for each cluster?
Yeah, I do think you need that higher level guidance, but I also think if we're going to continue to have disease-specific guidelines, which we do, because we do need to know how to give the best treatment for somebody with their chronic obstructive pulmonary disease, but we have to know how to provide the best treatment for people with that condition when they have multiple other conditions. And I do think our clinical guidelines, even for heart failure, but all the cardiologists will tell you that everybody with heart failure has got multiple long-term conditions. The guidelines focus on the heart failure, and there's usually a page at the end or 2 pages which says, well, if they've got this or they've got that, you need to consider this. I do think we need to integrate. There's very common conditions that coexist. We know, for instance, that depression is very common along with heart failure. We know that chronic obstructive pulmonary disease is very common along with heart failure. And we know that diabetes is very common. So some of these very common combinations, I think we need to be more clearly think of how do we provide integrated care for those and better care for them. So I just think we do need to think more widely about that. And of course, talking about specific guidelines, often there's self-management guidelines and rehabilitation guidelines. And again, they often don't take account of patients' ability to do the work of self-management or how we can improve their capacity to self-manage or support them. And I do think we need to start to rethink that a bit in terms of going forward.
I suppose in terms of the wider benefits of treatments that could treat multiple conditions, things like from a respiratory perspective, pulmonary rehabilitation, it's got a fantastic evidence base. It's nearly as sexy as a lot of pharmaceuticals, but could treat much more than just a respiratory condition.
Very important. And in fact, we've got funding right now from NIHR for a trial called Perform. And we're going to be doing rehabilitation for people with multiple long-term conditions to see the effects in that. Because again, here we have cardiology. If you have your MI, you can get your cardiac rehabilitation. If you've got your COPD, you can get your pulmonary rehabilitation. But actually, there's lots of individual conditions, chronic kidney disease and rheumatoid and other conditions that we know that exercise, physical activity is helpful to. And thinking about those commonalities, rather than having somebody with COPD and heart failure getting the pulmonary rehab and getting the cardiac rehab. Why don't we have these things which are quite generic? Lots of risk factors and lifestyle changes are generic. Think about how do we deliver services for that. And I'm hoping in the years to come, we might be able to be contributing to the evidence base to say, actually, that works. So why are we just choosing one condition? It should be these combinations of conditions to be put to more people to make a difference.
Brilliant. Just thinking again of our audience, many of whom will be internal medicine trainees of one stripe or another. Almost all medical trainees train in a specialty alongside internal medicine. And unfortunately, this is often seen as the poorer relative or perhaps a service provision component of training, perhaps with the exception of geriatrics as a specialty. Whereas conversely, clearly multimorbidity demands more generalism in medicine. How do you think we can foster or encourage generalism more among medical trainees to promote its profile and reduce perhaps the perception of it as an additional burden alongside training's primary specialty?
I think one of the things that needs to be done is a change in the way that major teaching hospitals prioritize and reward working. So I think there's a real thing that if you're wanting to be a major teaching centre hospital, you want to be a specialist or a super specialist. And we do want specialists, so I'm absolutely not against having specialists, but actually I think it's not sustainable for us to continue to not have some generalists in the hospital setting. I think we definitely need that for people under age 65, because I think it's just not tenable for us to not be focusing on that. And I think one of the reasons why I've developed the Multimorbidity PhD program for health professionals is to think that we actually need to move away from our single disease focus in undergraduate medical training, in our clinical training, in our postgraduate training, and think much more about multiple long-term conditions, because this is the challenge everybody's going to be facing globally, no matter where any of your listeners go to work in the world. It's not if they go to the US or if they go to Africa or Asia that it's not a problem, it's universal. And I think if you set them the problem and say you have people who've got 3 or 4 conditions, how would you configure a healthcare system? I don't think anybody would configure it the way it is just now. You would set it up quite differently. And I think we have to be able to make the more of an academic specialty in terms of general medicine to go, and to make it an area where high flyers will want to go. And I'm not sure how we backpedal from this, because in fact there used to be general physicians and suddenly we've moved to this very specialised care. And part of that is because of the complexity and all the advances in medicine, and actually it's difficult to be competent in various procedures unless you're doing enough of them at a time. But I do think we do need more generalists in the secondary care sector to be able to accept from primary care this. And we still need the specialists so they can get input and advice from for that. But I think we need a bit of rebalance. I think we've kind of gone out of kilter with what the needs of our patients are just now.
I suppose, I think the Shape of Training report, it was quite a while ago now that it was published, but was looking at trying to promote more generalism and slowly filtering through its internal medicine training. Now the first stage of it is a bit longer to front load some of that generalism. So hopefully we will increase the profile of that, and perhaps the college might have a role in that too.
I think it is very much for the next generation coming up to transform and move in that direction, because I think it's very hard if you've been specialising in diabetology, or you've been a cardiac electrophysiologist, or you're respiratory, and you haven't been doing that much general medicine, for instance, to suddenly go back to kind of think, well, I'm de-skilled and that's not where my expertise is. So I think we want to stop people getting this de-skilled and actually have, I think, a cohort of people who are generalists, a bit like the general internal medicine physicians that you have in the US. I think we need more of those who are in the hospital setting, for definite.
Just before we wrap up, coming back to research, I wonder if you could touch on some of the implications of multimorbidity for research, which are perhaps slightly different in clinical practice. For example, multimorbidity is often quite obvious, as you describe, when we're faced with it clinically, but trying to define and identify it in research can sometimes prove a bit of a challenge. What challenges have you encountered, and how would you suggest overcoming them in the research world?
So there are multiple challenges for this, and it ranges from just how you measure multimorbidity or multiple long-term conditions, because there's different ways of measuring it. Sometimes people measure by just a simple count of conditions. Sometimes people are looking at clusters and using very statistical methods to put people into different clusters of multiple long-term conditions. Other people use measures like the Charlson Comorbidity Index or Elixhauser, and there are other measures of long-term conditions, and quite a bit of dispute about how you measure it. There have been efforts made to try and develop consensus statements about how you measure multiple long-term conditions. I guess the consensus is it's really hard to get consensus. I mean, there are consensus statements, but not complete agreement. And this causes great difficulty, I think, also for clinical trialists. Number one, if we're wanting to look at the evidence for treating somebody with, say, diabetes, and we want to look at the clinical trial evidence and see, well, how does it matter if you've got multiple long-term conditions? Will these treatments be as effective in the person who's got diabetes only as they are in the person who's got diabetes and 5 other conditions? And there's lots of potential to do meta-analysis of trials and things like that, but it's very difficult to do that if your definition, how each of those trials defines multiple long-term conditions differs, and if they only measure a certain number of multiple long-term conditions. So I do really think there's a need for consensus, for instance, for clinical trials to have a core data set of, we want to have at least these, 20 top conditions that we measure or we report on consistently, so that there's the potential, for instance, to look at treatment effects based on multiple long-term conditions, because I think we need to know more about that. I think there's also the problem for recruiting to clinical trials to say, again, people tend to treat people with multiple long-term conditions as if it's a homogeneous population, but actually it's a very heterogeneous population. Somebody who's got heart failure and diabetes and schizophrenia is in quite a different situation from someone who's got eczema and osteoarthritis. So really quite different. And so there's a question about when you do interventions to help people with multiple long-term conditions, about how we define it and who we include in these interventions. I mean, one of the things I think is really fascinating about doing research in this field is the complexity of it and trying to determine for trials who are your populations and what kind of interventions and how might it vary depending on the kind of pattern of long-term conditions that they have. And then also in the epidemiology about how you look at that as well. And there's a whole huge area of research that can be done round about digital health and the opportunities that artificial intelligence might present in terms of bringing together data from primary care, secondary care, social care, mental health services, and bringing them together. And is there a way that we can quickly make such information easily understandable by a clinician seeing somebody in a 10-minute appointment quickly? And I think the answer is there's a lot being invested in. I think the answer is potentially in the future, absolutely. Because that's one of the challenges when you see somebody in hospital with multiple long-term conditions, is trying to make sense of what happened when and why they're on this medication and all of that. And if there was some way you could do that in an instant, actually, you could spend more time talking to the person sat in front of you about what their challenges are and what their goals are and their treatments. But of course, we spend so much time trying to get a handle of the person who you've never seen before. What's wrong with you? Why are you on this medication? Are you having problems with it? And all of this kind of thing, trying to look at the blood results quickly. That's a challenge. So I do think there's a whole area of research about how can we help to deal with these people and give them better care, not just through the way systems are organized, but using new technologies in an equitable way that helps us for everybody sat in front of us. So I think there's lots of exciting areas of research about how we measure it, how we intervene, who we choose to intervene with. So I kind of very much watch this space, and I think a really interesting area for any clinician to do in terms of intellectually challenging research.
Absolutely. And it's so exciting hearing the other researchers within the Multimorbidity PhD program that you head up and all their various projects. So perhaps we'll add a link to that program in the podcast notes so that people can find out more about that, along with the NICE guidelines. Frances, thank you so much for coming on to talk to us today about multiple long-term conditions and its relevance to physicians of all stripes. I'd just like to give you a quick opportunity if there are any final thoughts or take-home messages you'd like to share.
First of all, thank you very much for asking me along. I hope it's of interest to your listeners. I guess it's just a plea to think about the people who've got multiple conditions and the work that they have to do of managing. And I think just putting yourself in their shoes just for an instant, thinking, gosh, how would I cope if I had to go to work every day and I had to take 20 tablets and I had these 5 health conditions? How well would I manage them? How well would I enact all the lifestyle changes, and how would I manage all the appointments and still go to my work and do the other competing tasks? I think just thinking about that a little bit when you're managing these people, these multiple conditions, will be helpful to them in thinking of your planning and the advice that you give.
Brilliant. Thank you once again so much for your time. It's been a real pleasure talking with you today.
Thank you very much.
TNMC's sister podcast, Career Conversations, which supports medical students and trainees with career guidance and progression, as well as professional development. We wish to recommend our Demystifying PACES podcast series on career conversations. As some of you may know, in late 2023, MRCP UK updated the PACES exam format, so we developed this new series to support PACES candidates. Episodes cover exam organisation, calibration, every PACES station including key changes, and candidate perspectives.